Sound check, sound check. Okay, folks, here we are in part 6 of the TMC review sheet videos. This starts with item 404, and I believe we're up to about 510 or 512. So we got 100 items to cover here. Might as well get started. Let's do a share screen, share computer sound, optimize video, and that should share my screen so I can put up the TMC review sheet video here. Make it a little bit larger so you can see it. The review sheet comes to exist as we talk to students about the exam. They come back and they say, I wish I had studied more about this topic or that topic, or I was surprised to find a particular topic on the exam. So we put those things on a review sheet to help you do better on the exam and gradually over time to improve the performance of the program. So number 404, cachexia, C-A-C-H-E-X-I-A, is a term that's showing up on the exam. It simply refers to wasting or wasting away, loss of body weight, muscle atrophy, fatigue, weakness, significant loss of appetite. And this is a decrease in body mass, less fatty tissue. We see this in a variety of conditions, cancer certainly, AIDS, celiac disease, COPD. We do see sort of a wasting away of our COPD patients over time. I'm sure you've probably noticed that. In clinic, these folks tend to be very thin. Multiple sclerosis does this, rheumatoid arthritis, CHF, and tuberculosis. So that's cachexia, and it could very well show up on your test. Now you know what we're talking about. Glasgow Coma Scale. Yes, you do need to know the Glasgow Coma Scale. Any score 8 or below is considered comatose, and that's the reference that students have been seeing on the test, is a Glasgow Coma Scale less than 8 is considered comatose. We have not had any students who had to actually formulate the score, so I'm not going to spend a lot of time going over the individual scoring. It includes eye-opening on response, best verbal response, best motor response, and then a total score. Comatose is 8 or less. 15 is an ideal score. Totally unresponsive is 3. You might go ahead and put that in your head, that totally unresponsive is a Glasgow Coma Scale of 3. Take a quick look at that. You definitely are going to see this on your test. A score of 8 or below is comatose. 406 is Pulmicort budesonide. It's dosed every 12 hours. We have had numerous students come back from the test and say they needed to know the dosing schedule. It's every 12 hours. Physical findings: dullness on percussion, decreased tactile fremitus, and diminished breath sounds. That combination goes with pleural effusion. So you could have a question where they say your patient has dullness on percussion, decreased tactile fremitus, and diminished breath sounds. What is that? Well, it's pleural effusion. Number 408, use of accessory muscles is commonly the result of what? Most commonly, increased airway resistance. Accessory muscles kick in when it's difficult to move air through the airways, and that is increased airway resistance. Okay, let's look at number 409. Your patient's on mechanical ventilator 24 hours post-drug overdose, now alert, oriented, and stable. Pressure support 3, FiO2 35%. That's pretty low oxygen setting. Alert, oriented, stable. 7.47, just a little alkalotic. CO2 36. So we've got bicarb 24, oxygen 120. These are really very good blood gases, aren't they? Tidal volume 470, MIP 39, respiratory rate 14. So what they're doing here is painting a picture for you of a patient that's ready to be extubated. He meets all criteria and should simply be extubated. You don't need to do any long-winded weaning program for somebody who's that strong. All right, number 410, doctor orders 1 milligram of a particular medication for aerosol. If the concentration of the stock solution is 0.05%, How many milliliters of the solution should be given? When I was a student, I hated these calculations. I'll just be honest with you. But you could see one. So all you do is you take the 1 milligram and divide it by 0.5 milligram per milliliter, which is the same thing as 0.05%, and you find out that you need 2 milliliters. 1 milligram divided by 0.5 milligrams per milliliter, that's the definition of 0.05%. That gives you 2 milliliters. Just a hint, if you calculate this and it comes out with some crazy number like 20 milliliters or 200 milliliters or something like that, or 0.2 milliliters, then it can't be right because we've never nebulized those kind of volumes. So at any rate, hope you will be able to do that better than I did when I was a student, but calculating the volume of your medication could come up on your test. 411, which alarm is most crucial for ventilator transport? That would certainly be disconnect. When we're moving the patient, is there greatest risk for possibly disconnecting or becoming extubated? So definitely a disconnect alarm is most important. Immediately after intubation, you hear good sounds over the right, but absent breath sounds over the left. What does that indicate? Well, some questions on this test seem to be pretty darn obvious. This is the tube down the right main stem. And yeah, I mean, you're going to have questions like that. You think, wow, it can't be that easy, but this time it really is. It's just the tube down the right main stem. 413, your CHF patient tells you he breathes much better when he's sitting in a recliner chair versus laying down in bed. What is that called? Well, that is termed orthopnea. Orthopnea. Literally, that means straight breathing. The CHF fluid is filling up the patient's lungs when he lays down, so he breathes better when he's sitting upright. Our pulmonologist here at our program refers to that as 2-pillow, 3-pillow, 4-pillow orthopnea. How many pillows does the patient have to prop up on in order to breathe at night? So you definitely could have orthopnea on your test. Vein respirometer, what an odd term. We know this thing as a right respirometer, WRIGHT respirometer. You've probably used it to measure volumes, and it does have veins in it, by which we mean little flaps that spin around to measure the volume. So you could call it a vein respirometer, but nobody does. So on the test, when you see vein respirometer, just remind yourself that that's the same thing as the right respirometer, the right we've always used to measure volumes. 415, your patient demonstrated paradoxical movement of the right chest as he breathes, multiple fractures of 4 adjacent ribs. What is that? It's flail chest. You definitely need to know the definition of flail chest, which is actually 3 or more ribs. Let's add that here. Definition of flail chest, 3 or more adjacent ribs broken in 2 or more places. Okay, so this patient qualifies, unfortunately, and does have flail chest. If you've never seen it, you'll be amazed when you see it. The chest actually sucks in the area of the flail. 416, doctors on staff are ordering medication nebulizers inconsistently, sometimes when not indicated. What do? Well, that's where the therapist-driven protocol comes in. And the NBRC loves protocols, so they may very well have one on your test. Basically, this is a set of criteria where the RT decides what the patient needs and how long they need it. It's much better than family doctors trying to order things that they just really don't know very much about. So protocols, therapist-driven protocols is the answer. Beta-2 agonists, you use these medicines all the time, but you may not have heard them referred to as beta-2 agonists. That's what they are, albuterol and levoalbuterol, which is Zopanex. And they stimulate the beta-2 receptors to open up the airways. All right, now you'll know that term goes with albuterol and levoalbuterol. The servo-controlled heated humidifier on your ventilator is set at 30. Well, folks, that's quite a bit below body temperature, right? Body temperature is 37 centigrade. So if a patient has thick secretions, a smart thing to do would be to increase the humidifier temperature. It's too low. So you need to be able to recognize that and get it up closer to body temperature. The CVP catheter, where should it be located? Well, the tip should be in the superior vena cava, just above the right atrium. You probably knew that, but if you didn't, that's the exact location where the CVP catheter should float, and that could show up on your test. Vibratory PEP is the therapy to support any patient where secretions need to be mobilized. So things like cystic fibrosis, bronchiectasis, any condition, chronic bronchitis, where the patient has excessive secretions and we need to mobilize them. That's where vibratory PEP is most helpful. Okay, when CaVO2, that's the AV difference, the AV content difference, when it's increasing, what is happening to cardiac output? Well, cardiac output is decreasing when the AV difference is increasing, and that has to do with extraction of oxygen at the tissues. When the blood flow is poor, the blood moves through the tissues very slowly, a lot of oxygen gets extracted, and you have a bigger difference between arterial and venous. That's not a good sign for the patient, by the way. But AV difference increasing means cardiac output decreasing. Respiratory protocols, why are they so important? Well, they're important for improved patient outcomes. There are other things that they affect, but most important is improved patient outcomes. So you could have a question about that on your test. Can mean airway pressure cause a decrease? Can increased mean airway pressure cause a decreased urinary output? Well, that may seem like a distant connection, but it's really not. Because of the decreased venous return to the heart, what we call an internal tourniquet effect. I'm going to add that here because it may help some students to realize what's going on there. Internal tourniquet effect. That causes decreased cardiac output and thus decreased perfusion to the kidneys, and then we see a decreased urinary output. Okay, curly B lines, students are seeing these on the test. Curly B lines are short horizontal lines on the chest x-ray, and they indicate congestive heart failure. This is actually fluid surrounding the small airways. Fluid surrounding the small airways makes this line appearance, and that is congestive heart failure. Curly B lines, CHF. CHF is characterized by fluid leakage into the interstitium, and as a result of the increased pressure in the capillaries, fluid leaks, seen as curly B lines. It's Kerley B lines, and they're usually near the periphery and also near the costophrenic angles. Number 424, the 6-minute walk test. What should you have connected to the patient during the walk test? Well, definitely an oximeter. We definitely need to know if the patient is desaturating during that walk test. So definitely have a pulse ox attached to them while they do it. Oh, how much of an increase? I'm going to add that. How much of an increase in the 6-minute walk test do you need to see that the patient has improved as a result of their pulmonary rehab? Well, it's 15%. A 15% increase in 6-minute walk test shows improvement from pulmonary rehab. All right, that could show up on the test also. Let's scoot that next one down to the next page. IU ratio and inspiratory time percent, expiratory time percent. It's just math, but making sure you understand. If the IU ratio is 1 to 2, that means you've got twice as much expiratory time as inspiratory time. Then inspiratory time is 33%, expiratory time is 66%. Okay? Very simple point, but it could show up on your test, so we want to make sure that you get it. Calculate tidal volume from minute volume and respiratory rate. Minute volume is 10 liters per minute. That's 1,000 milliliters per minute. Okay? And let's say respiratory rate is 10. Okay? So tidal volume, you've got 1,000 milliliters per minute, rate of 10. Wait wait a minute, that's not right. 10 liters is 10,000 milliliters per minute. Rated 10, tidal volume is 1,000. There we go. Which is a big tidal volume, but at least it gives you the example. So minute ventilation, 10 liters per minute is 10,000 milliliters per minute, right? And then a rated 10 gives you a tidal volume of 1,000. That's, unrealistic. So let's go ahead and make this thing 20, and then that becomes 500 and makes a better example for everybody that uses it. Ta-da! All right. When does inspiration end and volume control ventilation? Well, inspiration ends after delivery of a preset volume. The definition of volume control ventilation is that a specific volume will be administered and then the breath simply stops, okay? Pressure control ventilation is different. There you're going up to a particular pressure. The breath ends when you hit that pressure, and there are other examples, but this has been showing up on the TMC exam. When does inspiration end during volume control ventilation? The answer is after delivery of a preset volume. Number 428, pulmonary embolism. The VQ scan will show an excess of ventilation as compared to perfusion because the blood clot is blocking blood flow, which is perfusion, but the ventilation is continuing, uninterrupted. So you'll see an excess of ventilation as compared to perfusion. Number 429, the best paralyzing agent for a patient with status asthmaticus definitely is rocuronium. At the hospital, we just call it rock. And what it does is it paralyzes the patient briefly, allows us to do what we need to do, and then we can reverse it. So, best paralyzing agent for status asthmaticus, rock. What does a PaCO2 of 30 indicate? Well, that indicates alveolar hyperventilation because normal ventilation gives us a CO2 of 40 with a range of 35 to 45. So 30 defines hyperventilation, alveolar hyperventilation. How about the dosing schedule for Spiriva? We're seeing more and more patients on Spiriva, which is tiotropium. Well, the schedule is every 12 hours. Every 12 hours, just like Pulmicort. So it might help you to remember that both Pulmicort, which is budesonide, and Spiriva, which is tiotropium, are every 12 hours. Lorazepam is a good sedation agent for mechanical ventilation patients. You might have a question that asks you which of the following medicines would be good for sedating your patient, and that is Ativan, lorazepam. It's a time-honored, effective sedating medication, and it simply works, and we use it a lot. What position should the patient be in for nasotracheal suctioning? Definitely the sniffing position. Students are seeing questions where the catheter will not go. They can't get it to go in the trachea. The patient won't cough for them. So that means that the position, the head position, is wrong for the patient. So get the patient into sniffing position. Number 434, your patient's on diuretics. You should be very careful to monitor electrolytes, and potassium in particular, but electrolytes in general. The diuretics wash out those electrolytes, particularly potassium. Patient will often have cramps in their legs or their hands. That's a clue that their potassium is low. 435, what procedure is helpful in determining the site of bleeding in hemoptysis? Your patient is coughing up blood, that's hemoptysis. Well, the only way to really pin that down is bronchoscopy. We need to go in with a bronchoscope, find the source of the bleeding, and then figure out, why is that bleeding taking place. Static compliance and dynamic compliance, you just need to know the calculation. It's not tough, but students are seeing this on their test. Static compliance is tidal volume divided by plateau minus PEEP, and dynamic compliance is tidal volume divided by PIP minus PEEP. You just need to know those. Simple calculation should be okay. Students are seeing this CaO2 calculation on the exam. There aren't many calculations. Every student I talk to says, well, I only had 3 or 4 calculations. But we are seeing this one, and it's one of the harder ones to remember. Let's just be honest, that CaO2 formula is pretty tough. It's hemoglobin times saturation times 1.34. That gives us the bound oxygen plus PaO2 times 0.003, that's the dissolved oxygen. So you have to add those two together to get the total. If it were venous, it's just the same. It will be SVO2 times hemoglobin times 1.34 and PVO2 times 0.003. Typical dosage for albuterol for continuous nebulization is 10 milligrams per hour. That just has been showing up fairly frequently as a question. How much per hour when you're going to do continuous nebs? It's typically 10 milligrams per hour. Most common side effect of nebulized albuterol, the most common is tremor. We see lots of other things. We see rapid heart rate, anxiety and things like that. But the number one thing is just the patient feels shaky, jittery. We call that tremor. Number 441 is caffeine citrate. This is useful in kids with apnea of prematurity. I think it's kind of funny that these kids actually get their first cup of coffee before they leave the NICU. That's exactly what is in coffee is caffeine citrate. But we give them a little of that. It keeps them perked up a little better. We could also use theophylline. For this, but caffeine is commonly used to keep these kids a little more alert and breathing better. The 3-liter syringe is specifically for spirometer calibration. You cannot calibrate the helium system, the body box. You cannot calibrate the nitrogen washout. It's only the spirometer that gets calibrated with the 3-liter syringe, and that's the question that some students have been seeing. Nitric oxide, a side effect is development of methemoglobinemia. We knew that nitrite poisoning causes methemoglobinemia, but also nitric oxide administration to your patient can cause it. So that is a known toxic side effect. How about pulmonary capillary wedge pressure over 25? Definitely recommend diuretics. That's too high. Fluid is backing up into the lungs. And this would be most commonly, let's just add that, in congestive heart failure or pulmonary edema. All right. Why do patients often gain weight when they stop smoking? Well, it's metabolism. It turns out that like caffeine and some other stimulants, nicotine is a metabolic raiser. It stimulates metabolic activity. So when the patient suddenly loses that stimulus, their metabolism goes down, and patients typically do gain weight after they stop smoking. It's a trade-off that they're going to have to live with rather than to die of lung disease. But at any rate, why does it happen? It's metabolism decreases. Incentive spirometry, useful for preventing areas of alveolar collapse after surgery. You may be called upon to explain this to the patient on the test. It's useful for preventing areas of alveolar collapse after surgery. Autoclaving, the only technique which truly destroys all microorganisms on RT equipment. Unfortunately, we really can't use it for most of our equipment because it would destroy that equipment. You can't put plastic in there, for example. You can put completely metal instruments, McGill forceps. You could put the McGill forceps in the autoclave and everything would be fine. But most of what we use, the bronchoscope would be destroyed by autoclaving, for example. Just most of what we use cannot go in the autoclave. However, it is the only technique which truly destroys all microorganisms. So if you're asked what is the best pure sterilizing procedure, that's it. Variable respiratory pattern, those words are a clue that the patient needs an air entrainment mask. We say Venturi mask. Air entrainment more likely will show up for your testing purposes. But it's when the patient has an irregular, variable, very fast respiratory pattern, the Venturi mask is the right thing to do. I think you've noticed at the hospital that we don't do it very often, right? But it is the right thing to do. When CaVO2, AV difference, increases, that would indicate what? Decreased cardiac output. Okay, folks, that's a duplicate. I recognize that from 50 items ago, but it's an important point, and that what that tells you is that 2 different students told me that they saw that on their test and they needed to know that. So when the AV difference increases, that would be decreased cardiac output. Measured auto PEEP, you do an expiratory hold just before the next ventilator breath, and that allows you to measure auto PEEP. Okay, helpful for treating patients with bronchi. What is it? Vibratory PEP. Rhonchi are sounds produced by secretions. So PEP is a good therapy to use for secretions, and it just makes sense. Use the PEP to mobilize secretions causing the rhonchi. Tip of the CVP catheter, superior vena cava. That's where it needs to be. Trach button is useful for decannulation of the trachea while preserving the stoma. I bet you've seen patients with a button in place. They no longer have a trach, but we're not comfortable yet closing the stoma, so we give them a button, and it just preserves the stoma. 454, what can you obtain from a spirogram? Well, anything that you can directly measure, like inspiratory reserve volume, tidal volume, ERV, FEV1, all those things can be taken from a spirogram. But some things cannot. For example, the residual volume, we cannot reach the residual volume to measure it. We have to use helium or body box or nitrogen washout. Because we can't measure residual volume, we can't get the FRC or the TLC either, because the RV is a key component of those. All right. 456, infiltrate on chest x-ray, not improved after several weeks of antibiotic therapy. That should lead to bronchoscopy. Bronchoscopy is the only way to find out why the infiltrate is not going away. And obviously the concern is possible lung cancer, right? 457, flail chest, 3 or more adjacent ribs, each fractured in 2 or more places. You definitely need to know that, and the pattern you see with it is paradoxical breathing. Okay, 459 is orthopnea. We've talked about that. Oh, the critical life functions, 460. Ventilation, oxygenation, circulation, and perfusion. This is actually showing up very often on the test. Our Kettering seminar people use this approach very strongly, also do the Lindsay Jones people, to help you manage your patient in the correct way. It's 4 steps. Ventilation, make sure they have ventilation first. Oxygenation, then circulation, then perfusion. If you keep it in that order, you'll do the right things for your patients. Okay, patient's CVP is less than 2. What does that indicate? Hypovolemia. A low CVP means there's not enough total blood volume. Your patient's CVP is greater than 6. What does that indicate? Well, that will be hypervolemia. You could have either on your test. That's too much blood volume. Sometimes that too much blood volume comes from nurses that give the patient too much IV fluid. They're trying to rehydrate, and that's important, but we don't want to give them too much. Okay, your patient only responds to painful stimuli. That is termed semi-comatose. The term is semi-comatose, and that has been showing up on the test. General malaise refers to the patient feeling run down, weak, sometimes caused by electrolyte imbalances. That's a very common cause, actually. General malaise. Ascites is accumulation of fluid in the abdomen, and it's most commonly liver failure. Clubbing, the angle of the nail beds, most commonly in the thumbs, first finger, and the toes. That's where it shows up most often, and that's caused by chronic tissue hypoxemia. Low blood oxygen levels for a long period of time cause the nails to club. I bet you've seen that on some of your patients. Venous distension, engorged veins seen during exhalation. This could be CHF, kidney failure, liver failure, COPD, but venous distension, engorged veins, easily seen in the neck, typically seen in the neck. Seen during exhalation. All right. Your patient is experiencing dyspnea, severe dyspnea, and has pink frothy secretions. Well, that should be a clue to you that they have pulmonary edema. Pink frothy secretions mean pulmonary edema. 469, chest x-ray shows complete opacification of the left chest with a shift to the left. Now, you have already learned about these conditions that shift the trachea away or to, all right? Pneumothorax and pleural effusion shift the trachea away, so that's not this. Here we have the shift. The shift is toward the problem. The thing that does that is atelectasis. Complete opacification of the left chest with a shift to the left, atelectasis. Atelectasis pulls the trachea to the same side. Pleural effusion pushes the trachea to the opposite side. Okay, how can you determine that an arterial line is non-functioning? Well, you can't draw blood from it. You've probably got a damped waveform also, not a good waveform. But when you adjust the stopcock and try to pull blood back from it, it will not function. So that means the arterial line is no good, probably needs to be replaced. Your ventilator patient has a PIP of 35 and a plat of 20. All right, PIP of 35, plat of 20. What does that tell you? Well, you should set the high pressure alarm at 45, 10 above the PIP. All right, this is a common question we're seeing now. 472, during your COPD, during therapy, your COPD patient becomes dyspneic. What technique can you instruct them that might be helpful? Well, it's pursed lip breathing. When the patient is becoming short of breath, we give them pursed lip breathing, and that will allow them to exhale more fully and decrease their feeling of dyspnea. Yeah, I've used this for thousands of patients over the years, and it works. I got a little numbering problem, so I'm going to fix that as we go here. 471, 72, 73, 74. During manual ventilation, 473, you're using a 10 centimeter PEEP valve. You've seen the PEEP valve that we attach to the bag, but pressure readings are 15. Why is that? Well, the usual cause is that secretions have gotten in the PEEP valve. That's going to give you a higher reading, not accurate reading, so you need to get a new valve. In fact, you might just want to get a new bag in and a PEEP valve in that situation. It will not read accurately if there's secretions in the valve. 474, your adult patient is breathing at a rate of 30 with a tidal volume of 200. Okay, so that's 3 times 2 is 6,000 milliliters. That's 6,000 milliliters minute ventilation. After sedation, her rate is 10 and tidal volume 600. So that's 6,000 milliliters of minute ventilation. What ventilatory measurement has increased? Well, the minute ventilation is the same, but each breath is doing a lot more good for the patient. It's not just ventilating dead space, it's ventilating alveoli. So the minute ventilation is the same, but the alveolar ventilation has improved. Key concept, I hope you guys get that concept, is that when we get the patient to have a slightly larger tidal volume, they're ventilating their alveoli better instead of just ventilating dead space. 475, your patient has flail chest, severe pain. What sedation would you recommend? Morphine. In situations like that, the patient needs morphine, plain and simple. Don't withhold it or use something less, and then hopefully we'll get them off it. But at that time, when you've got a flail chest, you need morphine. Okay, your patient presents with sudden onset of dyspnea, cough, sputum production, and chest x-ray showing opacification. What observation finding or inspection finding is likely? Well, that sure sounds like a patient with pneumonia, and what we would see there is asymmetrical chest movement or lag on one side. Sometimes we hear it termed lag, delay of one side inflating, asymmetrical chest movement. The opacified area will not expand as well as the opposite side. Okay, best site for capnography sampling during SIMV, well, it's at the ET tube connector. That's going to be the most accurate place to sample your end-tidal exhaled gas and get the closest possible measurement. 477, patient with high airway resistance, which gas mixture will improve distribution of ventilation? It's Heliox. The lighter weight gas of Heliox, which is 70 or 80% helium, will distribute better through the lungs in patients with high airway resistance. 478, upon starting an IPVB treatment, your patient's heart rate is 78. After 5 minutes, it goes up to 90. What would you do? Well, that's a very common effect, folks, and that's not truly an adverse effect. If the heart rate goes up by 20, like 78 to 98, then we would stop the treatment, talk to the doctor about, do we want to continue or try a different medicine? But going up by 12, a lot of patients go up by 12. Our medicines are stimulants, and that's very common. So you would continue the treatment and monitor. 479, your patient's on transtracheal oxygen. That's a small catheter placed in the trachea itself. It becomes diaphoretic. tachypnic, cyanotic. What has probably happened? Well, most commonly that little catheter is blocked by a mucus plug, so you're going to have to replace it. That is a situation that happens fairly frequently with transtracheal catheters. There are some real advantages to those catheters, but they keep getting blocked, so they'll never be a primary form of treatment because of that. What would be a good outcome indicator for your department's bronchodilator QA program? Well, one thing you could do is say, do we get patients out of the hospital more quickly? Average length of stay in the hospital should go down if we have a good program. Maybe if we have therapist-driven protocols. If we're doing it well, patients will recover and be discharged sooner. Number 481, your patient is a 7-day-old neonate, 28 weeks gestation. She's having frequent periods of apnea and desaturation. Definitely theophylline, aminophylline as a respiratory stimulant is a good choice, say, or caffeine, which can be effective in that situation. You're performing therapeutic bronchoscopy for an adult patient. As you're working, everything goes black in your view. What's the likely cause of that? Well, you've lost your light source. The bronchoscope has to have, a strong light source in order to function. So the light source is disconnected, or maybe the bulb has burnt out. Those are like $400 bulbs that are in the light source for bronchoscope, but they do eventually burn out. So that one of those things has happened. 483, your mechanical ventilation patient has switched to CPAP. Initial ventilation shows the manometer having negative pressure swings during inspiration, and the patient's agitated. So what's causing that? You don't have enough flow. Insufficient flow will not meet the patient's inspiratory demand. That means they're going to be very uncomfortable, and you're going to see a negative pressure swing. They're losing their CPAP because we don't have enough flow set. That has to be fixed. Number 484, your patient tells you she does not want any heroic measures to lengthen her life. This should be documented in advanced directives. Advanced directives are where we document this. You probably have heard it called living will, and that's correct, but the official term is advanced directive. 485, your patient is oxygen dependent, travels with an E-tank secured in the back seat of his car. However, he sometimes keeps an extra tank, a backup tank, in the trunk. What's your advice about that? The backup tank should be secured in the back seat of the car. It's extremely dangerous to have any compressed gas cylinder in a car trunk, because what happens is the car gets rear-ended, somebody hits the vehicle from behind, the tank explodes, and the patient does not survive. Maybe the other driver doesn't survive as well. But it's very dangerous to have a compressed gas cylinder in any trunk. 486, during nasotracheal suctioning, the patient does not cough. You get watery secretion through the catheter, but the patient does not cough. Well, folks, anybody who winds up with a catheter in their trachea will cough. So we're not getting the catheter into the trachea is the problem. So we extend the patient's neck to sniffing position while passing the catheter. And when you get a good sniffing position, the catheter will go in the trachea. Number 487, erratic pulse is palpated on your patient. What would you recommend? Well, definitely you want an EKG to find out what that erratic pulse is. Those can be some PACs, which don't mean a heck of a lot. They could be PVCs, but they could be heart block. So you definitely want an EKG to see what rhythm the patient is in. 48, your patient is suspected of having upper airway obstruction. What's the best test for that? That's a flow volume loop. The flow volume loop will tell you if they have an upper airway obstruction. The loop sort of squares off if there's an upper airway obstruction. There's a characteristic pattern to that. Your patient is using a transdermal nicotine patch to stop smoking, complains of skin irritation and insomnia. Excuse me. Your advice, rotate the site more often. That will help with the skin problem. And discontinue use before bedtime. Unfortunately, sometimes these nicotine patches keep people awake. So consequently, they may just discontinue use a couple hours before bedtime. 490, if your patient cannot increase ventilation, if they cannot increase ventilation, let's say they're sedated, paralyzed, maybe they're even a quadriplegic, but then adding mechanical dead space will do what? It will always increase the PaCO2. If they don't have the ability to increase their own ventilation, and we put on dead space, the CO2 will climb. Which chest x-ray position will provide the best view of the apex, lingula, and right middle lobe? The answer is the lordotic view. That gives us a look down into the apex, lingula, and right middle lobe. Lordotic view. 492, when collecting equipment for an arterial line setup, the pressure tubing is in a sterile package, but the corner of the package is open. Well, folks, if that's open, it's not sterile. You cannot use any piece of sterile medical equipment that has any violation of the package. A little tear, an open corner, none of that is acceptable. 492, what percentage increase in 6-minute walk test indicates the patient's rehab has been effective? 15%. I mentioned that earlier when we were talking about 6-minute walk. There you go. 493, occlusion of the expiratory circuit just prior to the next ventilator breath helps you to measure auto PEEP. 494, when performing quality control on a blood gas analyzer, you notice the pH value is more than 2 standard deviations away from the control group mean. What should you do first? Well, that could mean something seriously wrong with the analyzer. But the first thing you would do is to remeasure the sample. Do you get the same result, or maybe was there an error of some kind on the first measurement? So remeasure is the first thing. This one I still consider very odd. I understand how it happened, but I just think it's very odd that QT means cardiac output. What that means is Q is perfusion, okay, and T is total. So total perfusion, meaning cardiac output. But you need to know, because on the test, when you see QT, you just need to realize that that's cardiac output. Cardiac output is equal to heart rate times stroke volume, and normal is about 4 to 8 liters per minute. And since we've got QT, meaning cardiac output, then cardiac index could be QT divided by body surface area. You sure wouldn't think of that as cardiac index, but it is. QT divided by body surface area, normally 2 to 4 liters per minute per square meter. On my test, I was asked for the units of cardiac index, liters per minute per square meter. Systemic vascular resistance, SVR, is calculated as MAP, mean arterial pressure, minus CVP divided by QT, which is cardiac output. MAP minus CVP divided by QT. Normally it's less than 20 millimeters of mercury per liter per minute, or 1,600 dynes per second per centimeter. You can always take the millimeters of mercury per liter per minute, multiply by 80 to get the dynes. 498, systemic vascular resistance. What increases it? Hypertension and vasoconstriction. 499, those are the formulas that I mentioned previously. I just wanted you to see them here together. CaO2 and CvO2, hemoglobin times 1.34 times SaO2 plus PaO2 times 0.003. And CvO2 the same, just using the venous numbers. Normal CaO2, 17 to 20 volume percent. Normal CvO2, 12 to 16%. So the difference is normally 4 to 5%. That's important because you're going to get a question that says the AV difference is 8 volume percent. What does that mean? Usually it means poor cardiac output. All right. 503, PFT accuracy. According to the MBRC, the Collins water seal spirometer is still the most accurate device. I think that technically that's true because it is a true water displacement measurement, but nobody does it anymore. It's just too much of a hassle to drag around that water seal spirometer. It's still the most accurate, but the devices that we've come up with to simulate it are so close now that it just doesn't become very important. On your test, if they asked you for the best device, it's the Collins water seal spirometer. 504, 3-liter syringe for spirometer calibration. You know it's accurate if it's between 2.895 and 3.105. 2.895 and 3.105 is the acceptable range for that 3 liters. And the flows we use are 2 to 12 liters per second. Here's just a review of the drugs down the EP tube and why you might use those. Narcan for narcotic overdose, atropine for bradycardia, Valium reverse for sedation, epinephrine for asystole, and lidocaine for PVCs. Now what you do is you double the IV dose. I don't think everybody knows that. You double the IV dose and then flush. That should say flush. with 10 milliliters of saline. Okay, shunt can be shown as QSQT. So they might use the word shunt or they might use QSQT, and it should normally be less than 5%. And then here's just a little summary of the weaning parameters. I think that you probably know those by now. Tidal volume greater than 5, vital capacity greater than 10, respiratory rate less than 20, minute ventilation less than 10, MIP greater than minus 20, MEP greater than 40, RSBI less than 100. A lot of people say 105 on that, so I think I'll make that small change. A gradient less than 300, QSQT less than 20, and VDVT less than 60. All right. So to wean, we usually turn down the SIMV mode, turn down the rate, decrease the oxygen, get them down to 60%. Once the FiO2 is below 60, then PEEP is reduced 2 to 5 centimeters at a time. Lowest SIMV settings are 4. SIMV 4, FiO2 40%, PEEP of 5. And for pressure support CPAP, the patient must be spontaneously breathing. All right, quick review of sterilization. Autoclave, 121 degrees centigrade for 15 minutes, truly sterilized. No plastic or heat sensitive items. Pasteurization is not sterilization, it's disinfection. Moderate temperatures kill vegetative organisms, but not spores. And it's 63 to 70 degrees centigrade for 30 minutes. Incineration. Several students have had that on their test. Why do you do incineration? To treat contaminated disposable items before disposal. Irradiation is gamma rays, used to sterilize packaged equipment. And then here's a quick review of your lab values. Sodium, potassium, chloride, bicarb, creatinine, BUN. These are all showing up on the test. Hemoglobin, hematocrit, platelets, WBC, RBC. These are the exact ones that I had on my own test. So you're just going to have to take some time and learn those lab values. Bowel procedure, that's bronchoalveolar lavage, helps to diagnose or treat alveolar filling disorders. We use a flexible bronchoscope, instill and aspirate small amounts of saline. Therapeutic lavage uses larger amounts of saline. Total flow, flow meter times factor. Here's an example of a Benny mask set at 5 liters per minute, 28%. The air-oxygen ratio is 10 to 1 at 28%. Total flow factor then is 11. 10 plus 1 is 11. Total flow is equal to the flow meter setting times that factor. And you just want to make sure that you have enough flow to meet the patient's inspiratory demand. All right, you need a total flow of 45. What flow rate do you need if you're on 40%? And you can back up through this and find that. 40%, 4 is the factor. 45 divided by 4 is 11.25. So set the flow meter at 12. I bet you'll have one of those on your test. 513, clinical observation is most commonly associated with right heart failure. That's peripheral edema. Peripheral edema. The right heart is failing, so pressure backs up through the venous system and causes edema. Definitive method for monitoring effectiveness of equipment sterilization, biological indicators. The only way to know for sure that you have killed everything. It's bacillus spores that are in the biological indicator. What trigger mode be most helpful to prevent air trapping? That's flow triggering. Flow triggering is most helpful to prevent air trapping. Major component of surfactant, phospholipids. Phospholipids are what comprise surfactant, allow them to do their job of decreasing surface tension. During mechanical ventilation, mean airway pressure will always change with what parameter? With inspiratory time. If the patient spends more time in inspiration, then they definitely will have a higher mean airway pressure. More inspiratory time means higher mean airway pressure. More expiratory time means lower mean airway pressure. What type of nebulizer can be used to deliver medications without changing tidal volume? The vibrating mesh. Aerogen is a particular type. 519, patient with postoperative atelectasis, PEP, will increase the FRC. And we want it to. We definitely want it to increase the FRC because that expands the alveoli, prevents atelectasis. 520, what's the most accurate and quick way to assess patients' response to changes in FiO2? That's pulse oximetry. We should still be doing blood gases, but change by change, we can go with the pulse ox. What two factors influence the oxygen concentration by a self-inflating bag? It's the oxygen flow and the reservoir size. Okay. This is important. Hemodynamics by condition. I found a great little chart that shows you, these hemodynamics are tough for people on the test. They really are. But this thing shows you for each condition how the hemodynamics change. For example, in right heart failure, the thing that changes most is CVP. So a very high CVP, right heart failure, or cor pulmonale. Everything else normal or decreased. In lung disorders, pulmonary embolism, pulmonary hypertension, air embolism, any of those things, the thing that changes most is pulmonary artery pressure. You might have a little increase in CVP, but everything else is normal. For left heart failure, mitral valve stenosis, CHF, and high PEEP effects, the thing that increases most is the wedge pressure. It's the wedge pressure. See that? 2 arrows up. You might have some increase in pulmonary artery pressure. Cardiac output will be down in those conditions. And then we got hypervolemia and hypovolemia. Hypervolemia, all pressures are up. That's an easy one to remember. Hypervolemia, all pressures are up. Hypovolemia, all pressures are down. Okay, folks, our review sheet is up to 522 items. Wow. So know these items and your performance on the TMC exam will significantly improve. I actually had a student come back last week and say that this review sheet was the reason that she passed the test. And she passed at the high cut score. So hopefully you are making the most of these review sheets and their videos that go with them. We're doing this one on Christmas Eve, as it turns out, and then I'm going to take tomorrow Christmas completely off. I will see you in the course, and I'm here to help in any way that I can.